Welcome to the debate. The focus today, it emerges from a clinical analysis of a profoundly challenging case, Monsi, a 24-year-old medical student. She presented with systemic lupus erythematosus, SLE, that was not just active, but, well, highly complicated. She suffered multi-organ failure, including severe class 4 lupus nephritis, acute pulmonary involvement, likely pneumonitis or ILD suggested by HRCT, serious serositis impacting the heart and lungs, and deep hematological issues.
Yeah, this is exactly the kind of case that, throws textbook protocols into immediate conflict with clinical urgency. It's a genuine medical crisis. We're talking renal, cardiac, pulmonary, blood systems, all demanding immediate, pretty aggressive intervention.
Right. And that conflict, that sort of tension between the diagnosis and the actual emergency, that's our central question today. When a patient presents with this degree of life-threatening organ pathology and definitive, classical immunological markers, strongly positive ANA, anti-dsDNA, anti-SM, should the immediate clinical management strategy be driven primarily by the, let's say, pathological severity of the critical organs involved, or by the unifying immunological diagnosis?
The challenge really lies in which framework dictates those crucial first, say, 48 hours of treatment.
So I'll argue that the definitive immunological markers provide the crucial unifying framework. The specificity, the high titers of the serology, they must dictate the targeted SLE treatment protocol. It allows us to move swiftly and confidently toward immunosuppression.
Okay, well, I'm going to argue pretty much the opposite. The immediate high-stakes severity of that class 4 nephritis and those acute pulmonary changes, I think that necessitates a primary focus on pathology-driven management. We absolutely have to ensure the initial broad differentials, things like severe vasculitis or maybe atypical infections, are fully dismissed. Because frankly, treating organ failure takes precedence over just labeling the disease, even when the lupus serology is strong.
Okay, but let's look closely at the immunological evidence we actually had in Monsi's case. We weren't dealing with, subtle findings here. She had strongly positive ANA with a textbook homogeneous pattern, high titer anti-dsDNA, and critically, a positive anti-Smith-Smith antibody. Plus, we noted low complements, C3 and C4.
I agree. That combination is, well, highly characteristic of lupus activity. The anti-SM antibody specifically, yes. It's often described as probably the most certain molecular fingerprint for SLE.
Exactly. The anti-SM is that highly specific marker that really pins down the lupus diagnosis. It differentiates her quickly from other possible systemic rheumatic illnesses like, say, rheumatoid arthritis or systemic sclerosis, which just lack the specific fingerprint. And this immunological certainty allows for the immediate, confident initiation of targeted multimodal therapy. We start hydroxychloroquine for long-term control, sure, but more urgently, high-dose corticosteroids or methylprednisolone pulses for crisis interruption, and mycophenolate mofetil, MMF, which is a powerful immunosuppressant specifically mandated for severe kidney disease like this.
Right, that's a compelling argument for, let's call it, therapeutic efficiency. But I feel it ignores the sheer high stakes of her clinical status at presentation. The diagnosis was established, yes, I grant you that, but the case is labeled complicated precisely because of the acute failure. Monsi wasn't just sick, she was crashing. Progressive shortness of breath, an SpO2 down at 93%, blood pressure soaring at 150-100 millimeters Hg. Acute kidney injury with creatinine already at 2.0 milligrams to deciliter, and, basically a shutting down of her blood cell factory, severe cytopenias across the board.
But the SLE diagnosis tells us why those organs are failing. Isn't that the key?
It does. It tells us the why. But what truly drove the therapeutic intensity? Have you really considered that the finding of class 4 lupus nephritis on the renal biopsy and those very concerning ground glass opacities on her HRCT chest scan, aren't those the variables truly driving the severity classification and the actual choice of induction immunosuppression? I mean, class 4 nephritis means we are dealing with the most aggressive, damaging form of kidney inflammation. It's a rapid road to renal failure. That diagnosis, derived directly from pathology, is what mandated the MMF and the aggressive steroid pulsing, almost irrespective of what the initial anti-dsDNA titer happened to be.
Okay, let's focus on that initial step then. Prioritizing the diagnostic procedures. You imply the pathology, that Class 4 designation, is the true driver because it mandates the specific drug MMF. But hang on, how do we even get to the biopsy in the first place?
Well, as you said, we had a high index of suspicion from the serology.
More than just suspicion, wouldn't you say? The strength of the serology, the anti-dsDNA and the anti-SM, coupled with the multi-system clinical picture, that provided the necessary clinical inertia, the justification to pursue invasive high-risk procedures like the renal biopsy and high-level imaging like the HRCT chest. Without that clear immunological evidence, the fever, the hypertension, the nonspecific effusions, the cytopenias, it could have led us down a vastly different and potentially dangerously delayed complex diagnostic pathway. We might have spent critical days focusing purely on, say, infection or maybe only on hypertension management. The immunological markers focused the search immediately on autoimmune-mediated end organ damage, and that's what justified the risk of the biopsy.
I see why you emphasize the efficiency, sort of focusing the search, but I would frame the risk assessment a bit differently. The specific management, the long-term prognosis, and frankly, the immediate risk stratification hinged entirely on that biopsy result. Let's imagine, if Mansi had presented with an identical clinical picture and identical serology, but the biopsy showed, say, Class 2 nephritis, a much milder, mesangial form, the urgency and the specific regimen would have been drastically different, right? We would likely skip the MMF entirely and use much less aggressive immunosuppression. Therefore, I'd argue the pathological severity as defined by the biopsy defines the necessary therapeutic intensity, making it the primary urgent focus, even if the serology provided the initial direction to look there.
That's an interesting point about the Class 2 versus Class 4 differentiation, definitely. But let's pivot slightly to the larger clinical context, addressing the differential diagnoses and mimics. My position here is that the immunological clarity allows us to rapidly streamline that whole process. The clinical findings, like the absence of joint erosions, the absence of Raynaud's specific skin findings, combined with that unique serological profile, allow us to consolidate the diagnosis to SLE much faster. And this rapid streamlining is absolutely essential when you're juggling multiple life-threatening symptoms at once.
See, I'm still not fully convinced by that line of reasoning when we look squarely at the immediate crisis. We can easily rule out chronic mimics like RA or scleroderma based on clinical absence, I agree. But the severe constitutional symptoms, the high fever, the weight loss, the rapid pulse, and the acute organ findings like the pericardial rub, the crackles in the lungs, the cytopenias, these were complex enough that acute, life-threatening mimics, like infective endocarditis or perhaps a severe, rapidly progressive vasculitis, maybe ANCA-associated vasculitis, absolutely remained on the complicated differential list, at least initially.
Isn't Mansi's multi-domain involvement itself the hallmark of lupus? The strong ANA raises the probability of SLE so incredibly high that we can confidently launch the required high-dose immunosuppression, while those final specific rule-outs like, blood cultures for endocarditis are still pending. This prevents a potentially fatal therapeutic delay.
I just don't agree that the serology truly negates the need for rigorous investigation into those acute, life-threatening mimics. Let's take the lungs, for example. Mansi had those ground glass opacities on HRCT. Now, while that's consistent with lupus pneumonitis or ILD, sure, it could also be an opportunistic infection like pneumocystis, especially in a patient presenting with profound lymphopenia, which she had. The pathology, the appearance of the lungs on the scan, and her actual need for oxygen support mandated a temporary, kind of all-hands-on-deck approach to stabilization. And crucially, it often mandates initiating empiric antibiotics or maybe anti-PCP prophylaxis before the definitive response to steroids is even seen. That immediate treatment is driven by the acute pathological finding, forcing us to broaden the approach temporarily despite having that strong SLE label already. Okay, you're highlighting the crucial step of infection screening, which, yes, is always mandatory in these situations. But let's turn now to indicators of disease activity and response, because I think this illustrates the long-term primacy of the immunological diagnosis. For chronic management, we absolutely focus on the immunological markers for monitoring. specifically low C3 and C4, which tell us the disease is actively consuming the complement system, and those high anti-DNSA titers, which we know correlate strongly with active lupus nephritis. These markers are predictive of relapse, and they structure our long-term dose tapering strategy.
That's an interesting point regarding long-term prediction, absolutely. But I would argue that in an acutely complicated case like Mancy's, the immediate life-saving assessment, the day-to-day, is best tracked by clinical markers. While C3, C4, and dsDNA are perhaps the stars we navigate by for achieving long-term remission, they are often lagging indicators in the acute phase.
How significant is that lag, though, and why should we discount them even initially?
Well, the critical clinical variables, Mancy's creatinine levels going down, the reduction in proteinuria, the recovery of her blood counts, her WBCs and platelets coming back up, and the rapid resolution of her serositis, evidenced by, say, the disappearance of the pericardial rub, those are the immediate determinants of her stability and her response to those initial methylprednisolone pulses. These pathological and clinical variables are what tell us if the patient is turning the corner right now, so they must hold initial priority in assessing the efficacy of the induction therapy. They often respond days or even weeks before the serological results, like C3-C4 normalization or a significant drop in dsDNA titer, become evident. You really have to stabilize the sinking boat first before you can confidently navigate by the stars, as it were.
I see why you emphasize clinical stability and those immediate response metrics. Stabilization is, of course, paramount. However, the foundational decision, the choice of mycophenolate mofetil over, let's say, cyclophosphamide, the initiation of hydroxychloroquine for the long haul, and the use of an ACE inhibitor for renal protection, that's entirely rooted in the SLE diagnosis. It's based on the long-term need to suppress the underlying known immunological processes identified by the serology. So, yes, the pathology dictates the immediate severity and the therapeutic firepower needed right now, but the immunology provides the sustained roadmap for achieving durable remission and hopefully preventing the next crisis.
I agree that the immunological markers ultimately define the disease and guide the long-term course, no question. But the case of Mancy, a young patient presenting with such profound end organ damage, that acute kidney injury driven by class 4 LN, the severe cytopenias, the impending pulmonary crisis, it really demonstrates the critical need for maybe intellectual humility. The sheer severity of the clinical pathology often forces the hand of the physician, arguably overriding the certainty offered by the immunological label in that critical initial phase. In complicated multisystem disease, I maintain that acute pathology and clinical urgency must always command the immediate response.
Well, thank you for illuminating these different yet clearly intertwined perspectives on the diagnostic hierarchy in these really challenging cases of complicated SLE.
And we encourage everyone listening to further explore the nuances of multi-system autoimmune disease and think about how clinical decisions are structured when facing both immunological certainty and acute organ failure simultaneously. It's rarely simple.
Thank you for listening to the debate. We hope you found this discussion insightful. And please don't forget to like and subscribe to Dr. Yogesh Akani's channel for more deep dives into complex clinical dilemmas like this one.